Thank you. As you can see, what we're dealing with here is large extravascular collections of blood coagulated, which is a hematoma, and it's a common sequel of trauma or post-surgical bleeds. And a few CT scan examples are shown here on the left. And you can appreciate that they come in all shapes and sizes, but one thing they have in common is they're very large. They can be upwards of a couple liters. The health effects of hematomas include pain, so they can be very painful. They can, if they're large enough, they can induce compartment syndrome or organ failure by pushing on the organ that's next to them and cutting off circulation in that organ. As well, they can get spontaneously infected if left untreated. With regards to treatment, there's actually very few options. Because hematoma is like a jello, it's not liquid, it cannot be really drained. So the only really efficient way to evacuate it is surgery. Over time, hematomas will liquefy themselves, so they will self-lyse. And then they can be drained with an indwelling drain catheter, but that takes weeks, so it's relatively inefficient. So what we're trying to do here is use boiling histotripsy to rapidly liquefy large volumes of this gelatinous hematoma and then aspirate it with a fine needle. So I won't go into explaining what boiling histotripsy is. It's been subject of a few previous talks. But what I wanted to mention is that it's based on acoustic micro-fountaining and subsurface cavitation that forms next to the vapor bubble. The proof of principle that boiling histotripsy can liquefy large clots we have demonstrated some time ago before. So now we wanted to focus on really optimizing the design of our transducers and exposures for real clinical scenarios that have different depth, size, and accessibility. And so here, our objective was to correlate the HIFU field with the boiling histotripsy cavity that forms in hematoma and characterize hematoma stiffness as well. So as an in vitro model, we used a freshly coagulated bovine blood poured in rectangular molds. And then we either used it right away or let it sit for 3 to 8 days. And after 8 days, it would retract or reduce in volume, so sort of compact. And then we characterized the shear modulus or stiffness of hematoma with an indentometer. And as you can see here on the right, the shear modulus of hematoma is actually quite low, and it doesn't depend on the degree of retraction or on on incubation. So it's very soft, softer than most soft tissues, and it's in stark contrast with intravascular clot, which is known to increase in stiffness over time. So now that we know that our target is pretty consistent, we took several different transducers. They have very different pressure distribution. In particular, they can work at different frequencies, and they have different focusing angles. And we produced boiling histotripsy cavities using these transducers under ultrasound guidance. I won't go through the parameter sets. They were fairly common for boiling histotripsy exposures, but I want to draw your attention to the set of lesions that are shown on the bottom, made using a different number of boiling histotripsy pulses. So obviously, the more pulses you deliver, the larger the lesion becomes, but at some point, that dependence saturates, so it doesn't grow anymore, regardless of how many more pulses you deliver. So we took that saturated size to serve as our benchmark measurement. So if we take the most focused transducer and make a cavity using that at 1.5 megahertz, the growth of cavity axially stops exactly at the first null of pressure distribution. If we operate that transducer at 1 megahertz, it becomes exactly 1.5 times larger than at 1.5 megahertz. So it scales with frequency in all dimensions, and it correlates quite well with the distribution of peak-to-peak pressure. Again, if we take the less focused transducer with F number 1, same thing holds. The growth of cavity stops right at the null. It correlates well with the distribution of peak-to-peak pressure. And at 1 megahertz, again, it becomes almost 3 times larger in volume. And same thing with F number 1.5. It's very unfocused transducer for something that's really deep. So we also wanted to reproduce these shear moduli in different in vitro phantom that is made with anticoagulated blood that we can coagulate back with calcium chloride and add some thrombin to try to see if we can skew the shear modulus one way or the other. And it turns out that adding thrombin actually makes the samples softer, which was not obvious before, but either way, their shear modulus is quite low, regardless of what we do. And adding calcium chloride beyond a certain concentration didn't change that either. So if we take the softest we got and the stiffest we got, which is 1.2 to 0.4, we can see that the axial dimension of lesion doesn't change anyway. It's only the lateral dimension that does. So in conclusion, we have shown that shear moduli of these large hematomas don't seem to change with time or retraction and are fairly soft. And we can correlate the cavity size and shape with the peak-to-peak pressure distributions. Now we can model all the different designs, and we will know exactly what the liquefaction rate would be and how we could go about addressing different clinical scenarios of hematomas. Thank you.
Questions? So I'll ask one question. Did you do the sonications at body temperature or room temperature?
These were at room temperature.
Room temperature. Would it matter?
Probably not.
Okay.
Is there a tissue in between the hematoma and the transducer, or just?
Not in this case. So these were sort of in vitro benchmark experiments. But I mean, in reality, of course, there would be.
So you will have to modify because of the absorption?
Yes, of course. Yes, yes. So we would need to adjust for that as well as aberrations. But in principle, if we had the ideal case scenario, if we have our target that deep, it's that large, we have that acoustic window, what do we do? So at least now we can address that.
I was surprised the frequency played a big role here in terms of 1 megahertz to 1.5.
Yes, and it's surprisingly scaled with the field. So everything at 1 megahertz is exactly 1.5 times larger than at 1.5 megahertz. So it's inverse with frequency, and we might go even a little lower.
The reason I ask this is because as you will try to do the volumetric treatment, there will be tissue changes. And those attenuation as well as the tissue properties will change. And it won't act exactly like this. It will, in fact, the growth will be towards the transducer.
I'm not sure
The point is that, okay, so wherever you put the focal point, right? If the volume is 2 centimeters, that's what you are trying to get rid of, the hematoma. So you will start from the very anterior part of that and move towards the transducer.
Right. Yes.
And if you keep that working in that volume, it will automatically start growing towards the transducer.
Yes, yes, it's all prefocal. You're right. Yep.
Okay.